Last speaker for today is Dr. Reni Philip, who is currently working as a consultant in Shankar Nethralaya, Chennai. She did her MS from Kottayam, and she's a trained research and clinical fellow from Shankar Nethralaya, and she's awarded the best outgoing fellow as well. She has several publications in various regional, national, and international journals, and she's also a prestigious contributor to the Shields textbook of glaucoma, South Asian edition. Over to you, Dr. Reni.
Thank you, ma'am. Good morning. Now that you've heard about the common techniques of Fields, the octopus, and the Humphrey, let us take a look at what other visual field modalities we have currently and in development. So we have come a long way from the time when Ptolemy first noticed the circular form of visual fields way back in 150 BC. And along with octopus, Humphrey, we also have shortwave automated perimetry, FTPs, virtual reality head-mounted perimeters, tablet perimeters, fundus projection perimeters, and eye movement or eye gaze tracker perimeters, and a lot of advances in AI, home monitoring, etc. that is going on. So we sometimes wonder whether these are as good as the established ones and what their current status is and scope for future development. We definitely would have an advantage having an alternate visual field technique that is helps in earlier diagnosis, is more accurate, accessible, and has a larger coverage, and can be used by the patient themselves easily. So these are a few of the devices that are available, as well as those in the pipeline. Due to time constraint, I shall restrict myself to one per category of the established devices. So shortwave automated perimetry uses a blue stimulus on a yellow background, as you can see here, when compared to the white-on-white perimetry. It is the S-cones are largely unaffected, and it's available on both the Humphrey and octopus. Though it's supposed to detect glaucoma earlier, this is a printout of the SWAP. You can see the SWAP mean deviation and of abnormal glaucoma hemifield test. And the OCT shows a normal RNFL, and this is the same patient, CETA standard, a year later. SWAP is, however, no longer recommended for glaucoma management because long-term follow-up studies have shown that the white-on-white stimulus detects as much a more field loss in glaucoma as SWAP, and also at least as early. Additionally, SWAP also has a few inherent problems with respect to nuclear cataracts, which act as blue filter, the time, and its limited dynamic range. The fundus projection perimetry, the compass, is designed with a scanning laser ophthalmoscope that is combined with an automated perimeter and can present the light stimuli compensated for the eye movements through the fundus tracker precisely on the area of the retina that needs to be tested. So this is the interface while doing the test. You can see a green circle here, that is the retinal tracker, and these points show where it has been projected. You also can monitor the pupil and the number of points that have been completed. So you can see here, if you're not able to see the fundus, the machine stops, such as if the patient goes back, the tracking is on hold. And the report shows, in addition to the projection and the sensitivities, which is reverse of what is there in the Fields printout, because it shows exactly where it is projected in the retina. You also have the staging system. And one thing to note is, instead of the VFI, we have the fundus perimetry deviation index from 0 to 100, where central points are more heavily weighted. And also that there's a fixation plot, but even if you have defects on that, it is not an indicator of the reliability of the test, as the machine corrects for the eye movements while projecting the stimulus, so that it does not necessarily degrade the test reliability. Progression analysis is also available, both the mean deviation as well as the FPDI, and cluster is also available on progression. There is good agreement between mean deviation in COMPASS and HFA, and the test retest variability was better than for HFA, and the testing times were similar. So frequency doubling perimeter is a portable perimeter that tests the ganglion cells along the magnocellular pathway, which is selective for glaucoma, and the tests are very fast, such that the suprathreshold testing can be even less than 1 minute per eye. This can be used in normal room lighting and is not affected by pupil size, and has an extensive normative database. The newer models, the Humphrey matrix, presents the reports in a 24-2 pattern with a stimulus size that is smaller than the Humphrey FTT 710, and also has connectivity to EMR and Forum. So the Humphrey matrix is faster than the CETA standard and has good agreement correlation between the mean and pattern standard deviation, but there is poor agreement with the glaucoma hemifield test of the two instruments. The head-mounted devices, ELISA is a representative advanced vision analyzer. It has 4 components, that is the head-mounted device, a patient response button, the controller device, and a back-end cloud server. The display system consists of a liquid crystal display. You have a Goldman size 3 stimulus, and test strategies include 10-2, 24-2, 30-2. It takes around 6 to 8 minutes, and eye tracking is present. This is a report on the AVA, and you can see that it says a low test reliability is there. One thing to note is that this printout shows a picture of how the patient's field is so that they can understand. This is helpful for the patient. But you see these 2 reports are taken on the same patient on the same day, and you can see that the glaucoma CETA shows it's normal, whereas this is unreliable and showing that there are defects. This is similarly another patient's report. The mean test duration was found to be similar, but the normative data is fairly less when compared to the CETA normative data. In addition, when you look overall at all the head-mounted devices, the range of contrast, a lack of normative data, and lack of progression data, and in some devices, the test duration is also longer compared to the Humphrey. So these are all areas where they should improve. The tablet perimeter, an example is the Melbourne rapid fields, where this is the fixation target, and white or gray spots come in the periphery, and the patient can tap at the touch zone. Depending on the size, the fixation may be in the center or in the periphery, and the patient can respond. There are 2 strategies. One is a radial orientation assessing 66 locations, and the other is like the 24-2 grid. These are examples of a normal eye, mild glaucoma, moderate, and severe glaucoma patients with the Melbourne rapid fields. There is a strong agreement between MRF and HFA for mean and pattern deviation. And progression data is available for a very small group of patients, where patients were asked to do weekly Melbourne rapid fields and a total of 5 to 6 fields of Humphrey. It was found that Melbourne rapid fields were less reliable than Humphrey, but the promising part is that the HFA GP analysis gave little bias from the MRF slopes. So, areas for alternative visual field technology to improve is in the sensitivity in early glaucoma, the measurement of progression and evaluation of advanced glaucoma, standardization of testing environment, the normative database, and we also need more validated results with adequate sample population. Currently, you can consider them for use in screening or use as an alternative in elderly patients, inaccessible patients, and in remote areas without access to standard automated perimeter. In future, we can hope for a system where fields are as easy as just sitting on a couch and doing it, with improvement of the existing devices. And in the pipeline, we also have eye movement or gaze tracker perimetry, home monitoring devices, and there is AI prediction of individuals at high risk of progression. Thank you. We shall now take questions, if anyone has any queries. Madam, what would you like to say about the macular versus the 10-2 program? Do you recommend doing the macular program now that you have the 10-2 available?
Earlier, only the macular threshold was done, but now with the availability of the 10-2, that is preferred because it has it tests a central 10 degrees and it has more test points, and so it gives us more information rather than the macular threshold. frequently is the 24-2C done in clinical practice? Dr. Chigita, would you like to take the question?
Actually, can be used in a general ophthalmology setup if you're expecting some central involvement, ma'am. Like routine glaucoma practice, I think we do 24-2. If we see central defects, we go for a 10-2. It can be used for screening purposes in a general practice setup.
Yeah, when you want to save time and...
In order to save time and patient can't do 2 tests.
Yes.
If you're just looking for a screening, if a patient comes with a family history of glaucoma or you suspect glaucoma suspects, those cases it can help.
in more advanced cases, you would definitely
if
do...
the definitive glaucoma clinical picture is suggestive of glaucoma, then I would go for 24-2 with the 10-2 if needed. Thank you.